Welcome everyone to our Fireside Chat today. Today is Fireside Chat number 175, and we have Professor Gireesh Reddy, who is going to be taking us through the topic of the day. So just before he starts, I'm just going to introduce him. So Dr. Gireesh Reddy is an accomplished consultant, interventional and transplant nephrologist, currently serving as an assistant professor and consultant at the Institute of NephroUrology in Bangalore, India. He holds a MBBS, an MD in internal medicine, and a DM in nephrology. Dr. Reddy further honed his expertise as a fellow in the Department of Interventional Nephrology and Vascular Interventional Radiology at Albany Medical Center, Albany, New York, the United States of America, where he became the first international fellow in his specialty. Dr. Reddy is a pioneer in renal endovascular procedures in India, introducing innovative techniques such as the Devan Shram technique for recanalizing chronic total occlusions of the thoracic central veins, and snuffbox radial artery access for vascular access salvage. He has held significant positions at various institutions across India and is recognized as the first nephrologist in the country to complete 500 endovascular procedures for vascular access salvage. His areas of expertise include vascular ultrasonography, peritoneal dialysis catheter insertions, and vascular access surveillance. Dr. Reddy has also conducted numerous hands-on workshops, training healthcare professionals in advanced nephrology techniques and establishing vascular access clinics across South India. Dr. Reddy will be taking us through an overview of interventional nephrology, case-based insights. Dr. Reddy, the floor is yours. Thank you.
Thank you, Dr. Mazhar, for your very kind introduction. Thank you, Dr. Vincent Lloyd, sir, and thank you to the entire team who are gracious and kind enough to have me on this platform. It's always a pleasure to interact with our colleagues, and our philosophy is. Vasudhaika Kutumbakam. The entire world, the entire universe is a family. So chatting with my colleagues is like chatting with my family. So let me go through this insight and see what I can add up to your existing knowledge on interventional nephrology. So I think I'll start my presentation. Today we are going to have an overview of interventional nephrology and case-based insights. So I always remember my teacher, Dr. Lal Kumbar, who has made me what I am today. I am very indebted to Dr. Lal sir and Dr. And other doctors who have taught me. And also I'm thankful to ISN, because it was through ISN Educational Ambassadors Program I got introduced to interventional nephrology and all the techniques of interventional nephrology. So let's define interventional nephrology. So the term has been defined as the branch of nephrology that deals with the establishment and maintenance of dialysis access, particularly arteriovenous access. In other words, interventional nephrology helps us to provide a 360-degree or a holistic care to the end-stage renal dialysis patient or chronic kidney disease patient. So with the use of traditional endovascular therapy, along with evolving pharmacological and biological approaches, interventional nephrology has a tremendous potential to change the spectrum of ESRD care for the better. Like, all of us are facing a huge burden of chronic kidney disease patient and thereby end-stage renal disease patients. And all of us know that vascular access is the Achilles heel for this end-stage renal disease patients. So with combination of all the skills like endovascular skills, pharmacological skills, and biological approaches, we can change the spectrum of care for the best of the patients. So what do interventional nephrologists do? We can start and manage dialysis access clinics, which can be designed, equipped, staffed, and supplied specifically for dialysis access management procedures. So what are the procedures we do in interventional nephrology, or in other words, what is the scope of interventional nephrology? So right from planning the access, uh, doing surveillance of access, monitoring the access, salvaging the access, and then providing a contingency plan and a future plan for access care. Everything is done by interventional nephrology. So these are the few headings or the basic procedures. So we do AV access angiogram, plasties, and stent deployments. We do AV fistulas and AV graft declots. Then we do peripheral venograms and central venograms. And obviously, because of catheters, when they get stenosed, we do angioplasty. And when they become chronically occluded, that is the chronic thrombotic occlusion, we do recanalize them and then open them up for future utilization of access. Obviously, tunnel HD catheters are inserted, exchanged, and fibrin sheath are lysed and disrupted. Then we do chemoport insertions. Then we do percutaneous PD catheter insertions. And then this is a basic skill, renal ultrasonography. And then we also do coil embolization of accessory veins when fistulas fail to mature. So these are the spectrum of procedures we do. Why is it important? Why is it to have interventional nephrology? Because all of us know the catheters are not good. If the catheter prevalence is more, then the relative risk of death is also more, and it was proven way back in 2001 about the relative risk of mortality with the prevalence of the catheters. So you see in this table, the prevalence, the relative risk goes up to the tune of almost 1.8 times with the catheters. And then it comes down with the graft. And then with fistulas, it gets better. So fistulas are the better access. And it is very important that all of us know that a fistula is a continuous circuit. So it begins at the left ventricle and it ends at the right atrium. So the entire circuit must be pathology free to deliver a good access care. So this is a good animation. Thanks to Dr. Tushar sir for this animation. So it begins at left ventricle and ends at the right atrium. So it's a continuous circuit. So any problem in this circuit will cause access dysfunction. So all of us know the access consists of three important things. One is the inflow, which begins from the left ventricle, the feeding artery, and the anastomosis. Then we have the cannulation segment or body of the then we have an outflow segment, and finally the entire axis ends in the central venous system and into the right atrium. So inflow issues can be difficult cannulations, negative arterial pressures, and low dialysis dose delivery. And then the uh, the cannulation issues can be prolonged bleeding, aneurysms over the body of the AVF, necroskin, and again low dialysis dose delivery. Then coming to the outflow issues. The outflow issues very common whenever we do dialysis rounds. We just look at the dialysis machines and then the venous pressures are high. Like, normally the venous pressure should be less than half of the blood flow. So if it's more than half of the blood flow, then we know we are dealing with some outflow issues. So increased venous pressures, prolonged bleeding, like the patient says that we have to hold the tourniquet for more than 2 hours or 3 hours, otherwise it will bleed. Then swollen limb, obviously because of central vein stenosis or obstruction, dilated and visible veins, aneurysms because of probably buttonhole technique or weakened outflow, then necroskin, again due to probably giant fistulas or mega fistulas, and ultimately because of access recirculation, there is low dialysis dose delivered. So I've told you what are the procedures we do in interventional nephrology. I've told you how to uh, pick up the cases which needs our attention and which are the cases for interventional nephrology. Now this is a small tray which we use for the endovascular interventions. So I'm just trying to introduce you to the endovascular interventions before I go into the case. So this is the tray which I always idolize, because this was a tray we used to use when I was getting trained in Albany Medical Center, New York. So it has a sheath, an introducer sheath. It has color coded syringes just to make sure that the particular syringe which is color coded contains a particular drug. Then we have a micropuncture set with a coaxial sheath, and we have various guide wires, we have probe cover, we have sterile ultrasound gel, and we have these trays and instruments. Once we have decided that we have to intervene in a particular patient for access issue, uh, there are multiple approaches to get across into the vascular access and cross the lesion. So one is venous approach or the access approach. In this, we can puncture the fistula or we can puncture the femoral vein. What are the advantages? The advantage is that because we are puncturing a vein, hemostasis is easier and can be achieved quickly. So because we achieve the hemostasis quickly, we can quickly discharge the patient after the procedure. So shorter duration of the hospital stay. What are the disadvantages or the cons? Sometimes, especially when you're declotting, you require multiple punctures and multiple access because you have to deal the inflow and the outflow. And in certain situations where we are dealing with failure to mature fistulas and we don't know which is the outflow vein as such, then this approach may not be beneficial. The second way of getting across into the dysfunctional axis is through the arterial approach. So preferably a radial artery, because either it's a radiocephalic fistula or a brachiocephalic fistula, the approach will be the same. What are the advantages? With a single puncture, you can access both the inflow as well as the outflow. So you have a better control towards the inflow and the outflow, especially when you're declotting the procedure. And it's more physiological because we are going through the direction of the blood flow in the axis. Now, what are the disadvantages? Sometimes it can be tough to achieve hemostasis, and thereby patient needs to be observed for a long time. So yeah, the hospital stay is also little prolonged, and technically it has a learning curve. So you need to perfect the art of puncturing the arteries. So this is my way, and this is something which is very close to my heart, a snuff box approach. So the advantages is that you are sparing the main radial artery for future intervention. So you are basically puncturing the radial artery in the anatomical snuff box. So this is the snuff box approach, and this we have started way back in 2017. Even before anyone else thought about this approach, we had started, and we have perfected this snuff box approach. So here I'm just going through the devices again. This is an introducer sheath which we use for all the endovascular interventions. And this is the balloon, the balloon dilation catheter. It's a ultra high pressure semi non-compliant. It's a balloon inflation device used to inflate the balloon and treat the stenotic lesions. And here you can see an ultrasound as well. So nowadays we do ultrasound guided interventions a lot. I would say ultrasound guided interventions are the way forward in all our nations. you know there are multiple advantages with ultrasound guided interventions. You prevent radiation for yourself and for the patient, and thereby you are minimizing the occupational hazard of radiation. Second thing is, it is easily replicable. You can even use your dialysis procedure room as an interventional suite if you just have a basic ultrasound machine. And then the cost is significantly cut down when you do ultrasound guided interventions. I think for all of us, where economics are really challenging, this is the way forward: ultrasound guided interventions. So let me now, before I venture into the case based insights, let me show you how a normal fistulogram looks like. So here you can see this is the forearm. Obviously it's a radiocephalic fistula. You can see the radial bone and the ulnar bone, and then you can see a guide wire across the vessel. So the sheath is in the radial artery, and then now we do a contrast injection. Yeah, so you can see uh, both the cephalic vein, the basilic vein, the axillary vein. So this is how a normal fistulogram would look like. Now we are seeing more distal or the central venous system. So here you can see this is the basilic vein, the axillary vein, the subclavian vein, and the brachiocephalic vein. Now we look how the central veins look like. So here you can see this is a digital subtraction angiography, because all the bony structures, everything else is digitally subtracted. Only the vessels will be highlighted. So you can see the trachea, the carina, the bifurcation, the major bronchi, everything in this, and the bones are completely gone because they are digitally subtracted. Here you can see this is the subclavian vein, this is a brachiocephalic vein, this is the superior vena cava and the right atrium. So this is how we do a fistulogram. We start injecting the contrast right from the body of the fistula, and we image it all the way up to the right atrium. Okay, so first case. This is an 80-year-old male patient on hemodialysis thrice weekly. He had coronary artery disease, so had angioplasty and stenting for the coronaries. And then he was initiated on dialysis, had multiple catheters, and he had delayed maturation of left radiocephalic fistula. And then currently, after delayed maturation, somehow the fistula functioned, and then he was on dialysis through the same fistula, but always his flows were very, very less. And they used to aspirate clots, thereby he had inadequate KT by V. We obviously diagnosed that there was some fistula flow issues. We advised him for fistulogram and repair, but he kept on differing. So one fine day, he presented with absent flow through the fistula. So the fistula was basically thrombosed. So all the management options were told to him, all the options were given to him, and patient chose for the endovascular declot. So we have punctured the right radial artery and put a 6 French sheath, and then there was a hydrophilic wire in the artery, and we did the angiogram. So this is how the angiogram looked like. You can see there are multiple collaterals because the primary vessel failed to mature. So this is the radial artery, and then there was a complete stenosis or complete occlusion of the body of the AVF. So we passed the guide wire and did an angioplasty. So once the guide wire passed, then we put across a ultra high pressure non-compliant balloon over the wire, and we did plasty. So this is the guide wire, this is the ultra high pressure non-compliant balloon. So just revising, this was the uh, angiogram. You can see there is no flow beyond certain point in the fistula, and multiple collaterals have developed here. And after we recanalized and did angioplasty, this is the, you can see that all the collaterals are gone completely. Only the fistula is visible. The outflow segment of the fistula is visible. So that's what the endovascular procedure can do to the patient. So all these collaterals are completely gone, which means the procedure was successful. So post recanalization, patient had a soft trill, good trill over the fistula, and now he continues to be dialyzed with the same fistula, and we dialyzed him with the flows of 350 ml. Then second case, a 53-year-old female, twice weekly hemodialysis. Again, coronary artery disease, and she had peripheral vascular disease. She had multiple access failure, and she came to us with absent trill over the fistula. So in this also we approached to the radial artery and put a 6 French sheath. And then unfortunately in this patient, she had brachial artery thrombosis as well along with the fistula. So here you can see this is a brachial distal brachial artery with the ulnar artery and the radial artery, and multiple collaterals have opened up because the main brachial artery was thrombosed due to retrograde migration of the clot from the fistula. So we crossed the first we put a catheter in the brachial artery and did an angiogram. The mid segment where the anastomosis is done is thrombosed. The brachial artery was thrombosed. So again, we did angioplasty. We macerated the balloon of the with the balloon. We macerated the thrombus in the brachial artery with the ultra high pressure balloon, and then we did an angiogram. And once the brachial artery opened, then we passed a guide wire across the fistula, across the anastomosis and the fistula. Here you can see the guide wire has crossed from the brachial artery into the AV fistula. The fistula has opened up. So initially there was some spasm in the brachial artery. So we thought that, probably this may not open up, but luckily for the patient and for us, the vessel has opened up and the patient continues to have dialysis through the same axis. You can see the entire outflow of the fistula has opened up. This is pre-procedural angiogram with absolutely no flows into the fistula. And this is the post-procedure angiogram with complete restoration of the flow. So a third case, 54-year-old male patient, again, same history, thrice weekly dialysis, multiple access failure, presented with absent trill over the fistula for the last 2 days. This was very, very tough case because patient was probably getting dialyzed through buttonhole technique, and there was no outflow vein for the fistula at all, and it was really, really difficult case. It took almost 4 hours for us in the cath lab to open this access. This is the basilic vein. This is the cephalic vein. It's a brachiocephalic fistula, and normally you need the contrast to go into the cephalic vein. But here you can see there is a big aneurysm because of buttonhole technique. A collateral has developed and the entire flow is getting diverted towards the basilic vein. So it was literally, there was no outflow vein at all, and we had to recanalize this patient. So first we opened up the anastomosis and the juxta-anastomotic portion. Then we plastered the outflow. So here you can see the outflow of the vein was completely occluded. There was no flow at all in this fistula. Finally, we somehow passed the guide wire after repeated attempts into the central venous system. Then we did a sharp recanalization of the occluded body of the AVF. And finally, we could establish a continuous circuit all across. So the outflow, the body of the AVF was opened up. The entire juxta-anastomosis, everything was opened up. And then we did balloon angioplasty of the entire segment of the fistula. Yeah, so this is before declot and recanalization. Yeah, you can see that the aneurysm flow has also reduced. There is a continuous circuit. This is the fistula. So the entire outflow vein of the fistula has been established. So you can see we have opened up the entire fistula and it is patent. So the patient is getting dialyzed through the same fistula. So this was one of the most tough cases. We took almost like 4 to 5 hours, but it was worth the effort because finally we had a fairy tale ending to this story. So this is a case of a very particular case. End-stage renal disease due to diabetic nephropathy. Patient had complete heart block, was on a pacemaker, and then unfortunately, without knowledge, they have done a fistula on the left hand, going by the dictum of creating an axis in the non-dominant hand. So a fistula was done on the left hand. Initially, a radiocephalic fistula, it failed. So brachiocephalic fistula was done. The moment brachiocephalic fistula was done, patient presented with grossly swollen arm. You can see it's a massively swollen left arm because of the brachiocephalic fistula and central vein stenosis. So we did an angiogram. So you can see it's a giant fistula. It's a big fistula. There is no flow beyond the subclavian vein because the pacemaker leads have incited foreign body reaction in the central venous system, and it was completely occluded. The brachiocephalic vein was completely occluded with no flows. You can see there is no flow at all across the central venous system. So we put a ultra high pressure balloon across the occluded segments, and we did angioplasty. After that, flow was completely restored. So here you can see, in this, there was no flow at all. There is absolutely zero flow across the central venous system on the left side. Here, you can see there is complete establishment of the flow across the central venous system. So, this is another most challenging technique because of long-term use of non-tunnel catheters and temporary catheters kept in place for a quite long time. Patients develop complete thrombotic occlusions. So we do sharp recanalization and open up those central veins and use them for new tunnel catheter insertions or open up the central venous issues in the patients. So here you can see patient had a left side non-tunnel catheter for a very long time, and because of that there is a complete occlusion. So there is no flow beyond subclavian vein in this patient. So the brachiocephalic vein, the superior vena cava are not at all taking flow. So there is a chronic thrombotic occlusion of the central vein on the left side. So we did a sharp recanalization. So this is what is a sharp recanalization technique. So here there is a TIPS apparatus which is used for a TIPS procedure in for creation of the portosystemic shunts. So they use a TIPS. So here we used a TIPS apparatus, and this is the sharp wire. This is a back end of the regular guide wire. So we did a sharp recanalization in this patient. You can see we have come through the femoral vein as well. So there is a long sheath which has come through the femoral venous approach. We are using this as the guide. We have recanalized from the left side and crossed into the occluded segment. We have crossed the occluded segment. Then finally, here, thankfully, the wire has crossed and it has so we established the continuity and then we did angioplasty. So this is angioplasty with ultra high pressure balloon. So the entire segment has opened up, and now the dialysis access is patent for this. So you can see there is complete restoration of the flow. So in the first image, you have seen that there was no flow beyond the subclavian vein, but here you can see the entire circuit has opened. So in our cases, we have seen radiocephalic fistulas, we have seen brachiocephalic fistulas, we have seen central vein occlusions with pacemaker in situ, we have seen complete thrombotic occlusions due to the non-tunnel catheter. So we have interventional nephrology can deal with all kind of access complications and give a better life for the patient. So thank you for your patient listening, and just remembering all my teachers, Dr. Arif Asif, who is the author of this textbook. I'm indebted to him because he set up me the training program. This is Dr. Gerald Method, father of interventional nephrology. These are my trainers, Dr. Kenneth Mendato, Dr. Keating, and Dr. Anil Agarwal, who is one of the pioneers in interventional nephrology. Thank you for your patient listening. So we need to nurture interventional nephrology for a better access care. Thank you.
Thank you, Dr. Gireesh, for your absolutely nice presentation, very visual and very practical. I must say that, as you correctly said, vascular access is the Achilles heel for hemodialysis patients, and I believe that this is one thing that we miss quite often in this part of the world. We do have it, but it's not as advanced as you are. Hopefully, we will have a few of our colleagues come through to your institution for training and hopefully expand our access to this kind of procedures to try and salvage the catheters, the vascular access, because once the patient has got access problems, that's it. It's more or less a death sentence for them unless they are very lucky. So again, thank you very much for your presentation. I've got a few questions. Perhaps maybe if I can take the liberty to ask before we go to the Q&A. So just a couple of questions. So in all the cases that you did show, majority of the times you have gone into the vessel and then done balloon angioplasty. Do you at times put in stents, like as you would do in arterial clots, to try and maintain the patency, especially if a patient, say, I think that was the third patient that was thrombosing all her accesses, probably she's thrombophilic from some sort. So would that be a case that you could use to save the fistula for longer?
Yeah, so that's an excellent question, Dr. Mazhar. There is a very clear-cut recommendations for stenting, and the dictum is to avoid stenting as much as possible, because there are multiple issues in this end-stage renal disease patients. Number one is they already have peripheral vascular disease. They have high uremic toxin load in the vessels. Then the CKD, MBD, all these are contributing to the bad results. And stents, they don't have long-term outcomes. Like, even stents also can stenose. So there is something called instant stenosis.
Yes.
So the general, and especially in the central venous system, once the stent stenosis, it's very difficult to open up that stenosis and provide patency. So there are clear-cut indications for stenting. One is when there is instant recoil, like you do an angioplasty on table, and immediately after angioplasty you do an angiogram. If the lesion recoils, like recoil on table, that is one indication where you stent the patients. Second indication is when the patient has presented within 1 month after angioplasty with the same lesion. So the recurrence of lesion within 1 month, that becomes another indication for stent deployment. And third indication is if there is any vascular tear that is threatening the vitals of the patient. So these are three indications for stenting. And then nowadays the direction is to do drug coated balloons. So especially in the central venous system, you use a drug coated balloon. So we have sirolimus coated balloons. So the main culprit in the recurrence of the lesions is neointimal hyperplasia. So neointimal hyperplasia can be prevented by using sirolimus coated balloons or paclitaxel coated balloons. So very lesser indications, and there are studies that have proven that the long-term patencies, like 1 year patency after stenting, is more or less equal to the plain balloon angioplasty only. So if you compare patients who just underwent plain balloon angioplasty and patients who have underwent stenting, the outcomes are more inferior than plain balloon angioplasty. So stenting is rarely done in our access cases. So after plain balloon angioplasty, we prefer drug-coated balloons.
Understood. Thank you. Thank you so much for the detailed explanation. Fairly clear. One more question from my side. So most of the time we do AV fistulas, but sometimes if we have got access, we can do grafts. So have you done any sort of non-conventional grafts? So I mean, when I was training for my nephrology, I read that you can get like necklace grafts and femoral to like the upper vein to the lower veins. So have you done any kind of these, I would say, heroic grafts?
So thankfully, my vascular surgeon colleagues are abundant in my city of practice. So I don't have to do those grafts, but my colleagues do femorocephalous grafts. They do femorocephalous graft, and in my own unit, we have harvested the saphenous vein and used that as a conduit for creating a brachiocephalic axis.
All right. Okay.
And then we can also use a saphenous vein and create a forearm loop graft.
Right.
Yeah.
Okay.
So these are some of the exotic accesses we have done.
Nice. That's good to hear. Because I've just read it in books, so it's nice to hear actually it's being done. So okay, so we've got a few questions from the chat. Carlos is asking a question. In your opinion, are there any restrictions for diabetic patients to have a fistula?
No, not at all. Uh, uh, the there is no hard fast rule, or there is no blanket statement that diabetics should not undergo fistulas. But that's an excellent question. Diabetes and access, because diabetes is a leading cause of end stage renal disease, and
Mm,
obviously diabetic accesses have their own issues. Number one
mm,
is primary failure is more among diabetic fistulas, but again the
mm,
culprit is we are creating fistulas at a very later stage, when the vessels are already damaged by the uremic toxins. So
mm,
that is why the KDOKI clearly says that whenever EGFR is less than 20, start
mm.
creating accesses,
Yeah.
because the vessels are much better. The elasticity is much better before they
Mm,
progress to the CKD stage 5. That is one thing. Second thing is diabetics and underdialyzed patients are a very bad combinations. Like some of
mm,
the patients, they prefer twice weekly dialysis. So
mm,
whenever I encounter patients with twice weekly dialysis, I'm
mm,
really on my toes, because the complication rate is very high. So patients
mm,
just think
mm.
that ultrafiltration is the only goal of dialysis, but that's not the case. These
True.
patients have very bad peripheral vascular disease. Their
Mm,
elastic recoil is very high.
mm,
So if we create fistulas in diabetics or in any CKD patients at an early stage, our
mm,
access failure rate will be much lesser. They will mature quickly. And second
mm,
thing is, if the fistula survives for 20 days, so what I tell my surgeons is, you create an anastomosis and make sure that the fistula survives for 20 days. After
mm,
20 days I will make this fistula mature, because I can do an assisted maturation by doing a balloon angioplasty. So simple ultrasound guided balloon angioplasty, the access
mm,
will mature and it will be ready for cannulation. So yeah, uh, with caution, but there is, every diabetic can undergo fistula, but obviously there are certain challenges. They fail, the failure rate is little high, but with
mm.
assisted maturation, with a good endovascular program, they are as good as a non-diabetic patient fistulas.
Thank you very much, Dr. Girish. Another question is from Dr. Amar, who is our colleague, a nephrologist as well. He trained in India. So he said, would you favor percutaneous interventions for a hemodialysis patient with evidence for ischemic heart disease before fistula creation to mitigate coronary steal syndrome, or subject the patient to a permanent catheter? This is a challenge we face in a resource-limited setting. And he follows up saying that do you use absorbable stents in your practice?
Yeah, that's a really excellent question. I should appreciate for the real insightful question about this. So yeah, one thing is steel is very common in patients with ischemic heart disease, but then
Mm,
a good vascular mapping before creation of the access. If we do a
mm,
good access mapping, then we can mitigate all these issues. Number one is, when you do mapping, you look at the arterial size of both the radial artery and the ulnar artery. So if you pick
mm,
up any arterial disease, then you can do an angioplasty of the peripheral arteries before you even create a fistula.
mm,
So doing an angioplasty of the peripheral arteries is advantageous in two things. Number one is, you will prevent the steal phenomena after the
mm,
creation of access. Number two
mm,
is, you will create a bigger vessel which will be suitable enough for creating a distal fistula. Say for example, a patient has ischemic heart disease. I do vascular access mapping for this patient. If I find the radial artery and ulnar artery are smaller, I will do a balloon angioplasty of the radial artery. By doing balloon angioplasty of the radial artery, I am increasing my size of the radial artery so that it becomes suitable for creation of a radiocephalic fistula. And
mm.
by creating a radiocephalic fistula, which is farther away from the heart, you have decreased the
Yeah.
chances of cardiac decompensation and load. And even
Mm,
when the patient's ejection fraction is around 30 or 25, if your
mm.
fistula flows are lesser, patients can still tolerate.
Understood.
So it has to be taken on case-to-case basis. And regarding the bioabsorbable stents, we are working in that process. We are collaborating with companies who manufacture these stents to come up with bioabsorbable stents. And that's a very, very novel concept and a novel thought process by Dr. Amar. I should really congratulate him for this innovative thoughts. And I really pray that Amar becomes an interventional nephrologist, because, that's an excellent thought.
Yeah.
Once we have the bioabsorbable stents, then the chance of instant stenosis, the chance of
Yeah.
jailing the contralateral veins, all are prevented. So
Right.
that's an emerging concept. But regarding the ischemic heart disease and access, it should be taken on case-to-case basis and individual basis.
Understood. Thank you so much, Dr. Gireesh. So Dr. Amar has got a few follow-up questions over there as well. So the outcomes for restenosis in plastide vessels and stented vessels are shown to be comparable. How often would you choose one over the other? And then he asks another question: how commonly are IVC pump cats and hepatic vein pump cats done nowadays in patients with multiple access failures and contraindication to PV?
Okay. Yeah. So thank you, Amar, for those questions. Uh, First, answering what is my approach in access salvage. So my approach is, I always oversize the balloon. Like, the conventional teaching says that you can oversize the balloon 30% of the vessel size. Say, for example, if the cephalic vein is 6 millimeters in diameter, you can go up to 8 mm or a 9 mm balloon. So once you over dilate the vessel, even if it restenosis, still the diameter is maintained to a fair extent. And then number two is, if you inflate the balloon adequately for more than 2 to 3 minutes, and if you use a ultra high pressure balloon, the patency rates are excellent. Our average patency rates are close to 18 to 19 months after plain balloon angioplasty in the peripheral vessels. Then most important thing is, I will say that doing an angioplasty is only 30% of the care. Rest 70% is following up the patient. Most important thing is ensuring his KT by V is adequate. Then putting him on drugs that prevent neointimal hyperplasia. Like nowadays, this DoStats, the HIF alpha inhibitors, are also showing a promising role in prevention of neointimal hyperplasia. Then usage of drug-coated balloons. With all these maneuvers, I stent patients very, very less. Like in my last 2 years of practice in Institute of NephroUrology, I have stented probably on 4 to 5 occasions. That's all. Only when there was instant recoil on table, then only I have stented. So I have least preference for stenting, and that is what the concepts are also emerging. Previously, the guidelines used to be stent all the lesions, but now last 2 years the guidelines themselves are changing with the availability of drug coated balloon. So my preference is always ultra high pressure plain balloon angioplasty. If lesion recurs, I use a drug coated balloon, and only if there is no choice, then only I stent the lesions. So that is regarding the first aspect. And regarding the femoral perm cats, that's another excellent question. So in femoral perm cats, there are two ways of looking at femoral perm cats. At what situation you are using the femoral perm cats? Number one is, are you using the catheter as a bridge before you create a long-term access? Like, you have initiated a patient on hemodialysis. You are in the process of creating a long-term access. So before a long-term access is created, then you are using a femoral perm cat. And the recent guidelines also suggest that in order to prevent the thoracic central vein stenosis, you can use femoral perm cats. Say, for example, you know that you are going to put a fistula in within a month or 1.5 month. So in that time, you can use a femoral perm cath as a bridge before you create a permanent access. And most important thing to be remembered in femoral perm caths is, number one, no matter where you puncture the veins, the catheter has to end up in the right atrium. So even if you puncture the femoral vein, the catheter has to be long enough to enter the right atrium. So we use 55 centimeter tip to cuff femoral perm cath. So number one is using a longer femoral perm catheter. Number two, if you keep the exit site over the abdomen. Normally the tendency for the femoral perm cath is to keep in the thigh.
Right.
That is not advisable because the hygiene in the groin is not good. There is a lot of sweating in the thigh region. So that is why the hygiene of the catheter is affected. Whereas if you put the exit site over the abdomen, it is as good as thoracic tunnel catheter. So our longest catheter with femoral is 1.5 years. Because we have kept the tip of the catheter in the right atrium, we have used a long catheter. So 55 centimeters tip to cuff and tip in the right atrium. The outcomes are as good as TCC in the internal jugular vein or in the and rarely, because we do sharp recanalizations, I have never done a trans lumbar or a trans hepatic catheters, because again the outcomes are questionable. If you have good recanalization techniques, then you rarely need those. But there are experts who have done like 30-40 cases, but I have never done those.
Thank you. Sorry, there are a few more questions. Are you okay for time?
Yes.
All right, fine. So we have another question from our colleague, Dr. Jacqueline Shaw, who is a nephrologist at our national hospital. She is asking about AV fistulas in children. What is your experience and recommendations versus placing perm caths instead of making fistulas for children?
Rather than saying children or adults, we should go by the vessel size. We should go by the vessel size and the vascularity of the patients. So the guidelines say if the vessels are adequate enough in diameter, then you can go ahead with a fistula. Say for example, in a child also, if the brachial artery diameter is around 1 or 1.6 mm or 1.8 mm, still you can go ahead with a brachiocephalic fistula or a radiocephalic fistula. And then our preference here is for peritoneal dialysis in children, but we do have fistulas created in children as well. And we do tunnel catheter insertions. You have to choose a smaller tunnel catheter. Like, in mid-sized children, we use 15 centimeters tip to cuff tunnel catheters, and outcomes are good in children as well.
Perfect. Thank you so much, Dr. Gireesh. So that's point taken. It's not the age of the patient, it's actually the size of the vessels that is what matters. Another question is, in terms of maturation of fistulas in diabetic patients, does it fail due to wound healing delay?
No, it's not due to wound healing delay. Actually, the factors that determine the success of the fistula is, number one, the elasticity of the artery. Number two is the size of the arterial incision. Like, if you're doing a distal fistulas, you should be general with the arteriotomy. So you can go up to 0.8 mm to 1 centimeter arteriotomy when you're creating a distal fistulas. Thereby, the inflow to the fistula is very, very high. And third thing is the other comorbid factors as well. Like, what is the CKD MBD status of this patient? What is the KT by V of these patients? So all these points matter. But if you create fistula early in the diabetics, if you are generous with the arteriotomy, and then if you do a good surveillance and monitoring, the outcomes are as good as non-diabetic fistulas. So there is no much, but only thing is diabetic fistulas need little bit extra surveillance. Once you have created fistula, keep asking the patient to come to you repeatedly once a week. Do a good examination of the fistula, do good Doppler study of the fistula, and then you have a low threshold for doing assisted maturation in these patients. Yeah.
Right. Thank you. Another question from Dr. Amar. He's apologizing for asking so many questions,
No.
he has observed punctures being taken over the stent on an elongated stented fistula, how detrimental can that be for the AVF?
Yeah. So that is why we avoided, especially you should never stent the body of the fistula at all. Because, a stent can never be cannulated. If we do stent cannulations, there is something called stent fracture. If it's a bare metal stent, because of the cannulation, the stent can get fractured, and it can end up in right atrium or some unwanted locations. So the stenting should be done only in the area where you are not going to cannulate.
Right.
So, and even if you're trying to stent the outflow of the fistula, stent graft is preferable. A covered stent or a stent graft is preferable. So thereby we can avoid all these complications.
Understood. Thank you. And then I think we're going to take one last question. It's 8 o'clock on the dot on this side. So we have a question from Dr. Mbumi, who is the head of department at the nephrology services at the National Hospital. And he's asking, what is the best approach to establish hospital access group? So basically a hospital vascular access group, I believe that is what he's asking. Do you have one in your center, and does your hospital offer training?
Yeah. So the best approach to the hospital group is number one, start doing access mapping and Dopplers yourself. The basic interventional nephrology starts from ultrasound, because I would go to the extent of saying ultrasound skills are probably 60 to 70% of your interventional nephrology. If you do good ultrasound, you are a good interventional nephrologist. So start doing ultrasounds yourself, then educate your technicians to do ultrasounds, because ultrasound has a very, very short learning curve. Like, you spend, one study has proven, there was a practical study which was done, 15-year-old boys and children were given ultrasound, and, they were taught for 5 hours, and then they were tested. So after 5 hours of training, these chaps have started doing ultrasound. So it is very, very easy to learn. And nowadays, I know that butterfly machine is spreading its wings across Africa. So the availability of ultrasound is also very, very easier. So start doing ultrasound yourself. Teach your technicians to do ultrasound so that they can screen the access and cannulate the accesses. And then most important thing is to establish vascular access coordinator. Train 1 or 2 technicians, senior technicians, to be vascular access coordinator. So what does a vascular access coordinator do? He comes to the cath lab, he assists you in procedures. He comes to the ultrasound room, he assists you in the procedures. He does the vascular mapping. He does the screening of the accesses, so that he will assist you. So having a dedicated vascular access coordinator, doing access procedures yourself, and thereby the standard of care automatically percolates among the entire dialysis unit. Like, once you have an interventional nephrology program, your dropouts of dialysis patients due to access failure goes down significantly. So thereby the quality of the unit increases, and your volumes obviously increase. So it's very, very doable, and I would be more than happy to assist for the formation of this dialysis access units, because I feel every hospital or every tertiary care center should have a dialysis access care team, and we'd be more than happy to assist to do this. Yeah, we do have a endovascular training program in our institute. So currently we have a 1-year training program. Then our national society sponsors a 6 months training program. And then I would be more than happy to assist. I would be happy to come down to your own center and train you people, and that would be more physiological and feasible, because you will be able to replicate these procedures in your own centers. So either ways, an observership program is something we are keeping it in pipeline. Our director sir is also enthusiastic to do this. So hopefully in near future we'll have international training programs as well. And I'm more than happy to come down and help you guys to establish this program, so that, as I told you, the entire universe is one family, and we want our nephrology family to grow.
Thank you, Dr. Gireesh. That was a perfect end to the presentation. We thank you very much for that. And as I said earlier, sorry, Dr. Ntarindra, please go ahead.
Yes, one last question. Just a small one. Now, do you use general anesthesia or local anesthesia? I mean, what are you doing these procedures?
So
or maybe
we do it under conscious sedation. We don't use general anesthesia. We use midazolam and fentanyl. We keep patient nil by mouth for minimum 5 to 6 hours. And then we use conscious sedation. We use midazolam and fentanyl. So that's how we do it.
Thank you.
Yeah. All right. Thank you, Dr. Ntarindra. He is our country medical director for Rwanda centers. Dr. Ntarindra is actually, I would say, the father of nephrology in Rwanda. So he's an old-timer, but yeah. So as I said, I was just closing up, and Dr. Lloyd, I'll end up with you. But as I said earlier, that we tend to not have these facilities on our side, and we tend to have patients that drop out from dialysis because of vascular access issues. And as you correctly said while answering a few questions, is that we unfortunately see most of our patients crash land. So the chance of actually seeing them earlier and getting fistulas done earlier is usually, a very rare occasion. It's unless if you actually, pick up this patient by mistake, they came for something else and they were screened and somebody did the creatinine. So that is the only time you can probably do that. Otherwise, most of the patients crash land. So we tend to then, place them on catheters, and sometimes the fistulas don't work, etc. So I think it is something that is very important, and I believe that it is something that that we should try and push. And we'll be very, very glad and happy, Dr. Gireesh, to actually have you here to give us this training that you valuably have acquired from your experience. To try and at least train those nephrologists, the surgeons that are interested in doing, because I believe that this thing will go a long way in improving the outcomes of our patients that are fairly young that come onto dialysis, and unfortunately their outcomes are not very good because of vascular access problems. So again, thank you very much. It was a perfect presentation, very elaborative, very pictorial, and I see a lot of thanks and comments that everybody enjoyed the presentation. So again, thank you very much. Dr. Lloyd, maybe a few closing remarks. Thank you.
Thank you so much, Dr. Gireesh. It was a wonderful session indeed, full of knowledge, full of insights, and a phenomenal amount of work and phenomenal work that you're doing out there. We really look forward to more interactions into East Africa, as Dr. Mazhar mentioned. I'm sure Dr. Jonathan and Dr. Shaw would be interested at Muimbili. At the same time, there will be other centers as well who would be really interested. So we will really have to sit down and work out. I will revert on this. And even actually, Carlos, our CEO, he was also talking about, this vascular access group, which is a very, very important concept that we have to build in each country. That is a very important thing. And so we'll have to work out as to how best that this can be worked out. And we will definitely keep in touch, and I will revert on this aspect. Thank you so much for this wonderful presentation, and enormous amount of work. And I'm so proud to see that there's so much of transformation in Bangalore. When we started in Bangalore, I remember in 1989 going to the city nephrology meetings. There were like 6 nephrologists. Today, the amount of quality, not only the amount of nephrology, but the quality of work done like this is phenomenal, I should say. And I'm really proud to see what you're doing, Dr. Gireesh. Thank you so much for this.
You were the pillar, sir. Thanks to your efforts, you were the foundation. Your foundation, your pillars were so strong that we are able to build on that. So it's all thanks to you and pioneers like you. And we are this part of the country is blessed by visionaries like you. So it's all your efforts, sir.
No, I think it's all of you all who are doing phenomenal work, and I'm in the group as well, and I see that work every day. So thank you so much, and I think we need to do lot more into Africa now that you all are so good and established now, and it's very easy for you all to do. And I will work something out so that we can do some good work in Africa as well. Thank you so much for
Absolutely,
your
sir.
opinion.
Absolutely.
Thank you so much.
Yeah.
Thank you,
sir.
Dr.
Thank you.